So I was asked to talk about whether we can learn from history. I think there is a lot, actually. And one of the very surprising features I've always found when visiting other healthcare systems is the extent to which people are able to give you a long-term perspective on the policies that they're talking about, often extending back before they could plausibly have had a career in healthcare. I certainly found this in Australia and in Canada and in Catalonia, where I've had conversations about these things. But this is not the case in the English healthcare system, and I'll perhaps reflect on why that might be towards the end of what I've got to say. Perhaps it's quite useful to point to some examples of where the opportunity, what sort of things you do learn when you look at history, because there are repeating themes, unfortunately, that you see in the way that policies are put together. Very often, for example, we have a lot of historical examples of poor conceptualization and logic models about causality. A tendency to confuse structure incentive problems with relationship or culture problems, a tendency to oversimplify or to assume that people will react in the way that policy predicts it will, and sometimes even contested framing of what actually is the problem and do we agree on it. This often manifests itself particularly in problems with objectives, and a particular feature of British policy making, in healthcare at least, is the tendency to try and set multiple goals for the same policy instrument. The most recent striking example of this is our primary care networks, which are seen by general practice as the salvation and the thing that's going to rescue them, seen by bits of NHS England as the way to stealthily introduce primary care at scale, and by the people running the integrated care systems policy as a method for building better integrated care at place. These things are not actually necessarily compatible with each other, and it's led to many of the participants spending quite a lot of time talking at cross purposes. The payment by results policy in the mid-noughties, introducing a payment model for hospitals, was also striking in comparison with other policy initiatives of the same sort in other European countries, for having many more objectives, including, in one case, an objective to increase the number of admissions, that being elective, and decrease the number of admissions, i.e. emergency admissions. So trying to do basically the opposite thing with the same policy instrument. So there's quite a lot to learn from that repeated pattern that I think is worth reflecting on. A second repeating pattern is the failure to really get a narrative that people get behind. The most obvious one of that is Andrew Lanza's reforms, which really didn't work in narrative terms. And there was a famous incident in which he met a group of nurses who were very disgruntled with what he was proposing to do, and said to them at one point, "I'm very sorry if my policy has failed to communicate itself to you," which possibly is the most extreme version of narrative failure that I've come across. But one could say that the NHS Plan 2000 had problems which were repeated in the long-term plan recently published, and indeed in the 5-year forward view, which was long lists of things to do, but without a compelling connecting narrative to explain what they're for, which may explain a bit about some of the challenges for implementation. Another lesson that has tended to go with that is the fact that people are often asked to implement these extremely complex changes as part of their spare time, without necessarily putting the resources into implementation that really should be there. And perhaps a final third example of where we got opportunities to learn is actually making sure that we've understood the change that we're implementing. History teaches us quite clearly about the need to distinguish between changes which are relatively simple from those which are complicated, and not to confuse them with the complex, and certainly not to try and use policy instruments that are appropriate for complicated or simple problems to try and solve problems which are complex. raises an interesting question about why has the NHS been relatively poor, learning from history. I mean, the first is that there's of course been a very large amount of managerial turnover. So in those other systems that I mentioned, the survival rate of chief executives may not be that brilliant as it is in it's certainly not good in the NHS, but there's much longer continuity of people who've been around and understand the system and understand the policy frameworks, and more of a tradition of specialist civil servants who stay in one place rather than are moved about. A second problem is a lack of evaluation of policy. Policies are not formally evaluated very well or very frequently. Indeed, there's an interesting anecdote of a special advisor at one point sitting on Sally Davis's desk, not a thing that you would normally think is a good idea, and berating her for commissioning evaluation that showed that their brilliant policies weren't really working. People don't really want evaluations that tell them things aren't working, particularly not politicians. So that means you've lost the opportunity to learn from mistakes. And I think there's a general lack of curiosity about the past, and a sort of feeling that it's a different country where things were simpler, and that the people were not as clever as we are now, and therefore we will not make the same mistakes again. All of these are a serious error, but there is something, I think, baked into the culture of the NHS which has made it less curious than it ought to be, both about itself and about its past.